Adopting pathways is always a slow process, and quite frankly, they should not be adopted 100%. These are guidelines, and you always want your physician to take the guidelines as a starting point and then to use clinical judgment to individualize this for each patient. Most physicians will accept the use of a 5-HT3 antagonist and a corticosteroid. We've actually been using this pair of drugs for almost 20 years now. The NK1 antagonists are newer. They came in within the last 10 years, and they're a smaller step forward, but a step forward all the same. So the adoption has been a little more gradual. It's not as much of a habit of the people who are coming out of training or have been in practice. In terms of obstacles, there are different types of vomiting that follow the administration of the stronger chemotherapies. Acute vomiting is the vomiting that happens on the day of chemotherapy, sometimes even before the patient can leave the clinic. Those we were used to, those we saw all the time. And when the serotonin antagonists combined with corticosteroids came along and were able to get very good control of those, the advantage was obvious. Delayed vomiting is the vomiting that may appear 2, 3, 4, even 5 days after the administration of stronger chemotherapies. Since this usually happens after the patient has left the clinic, perhaps even when the patient is home, sometimes the doctors and nurses will not even realize it's happening. One thing we've encouraged is for the doctors and nurses to stay in contact with the patient, perhaps to call a couple days after chemotherapy to try to see how the patient is doing, because even a good first day may then be followed by some days that are not so good. And we've encouraged the patients to talk to their doctors and nurses. We can't know what's happening at home unless we're told. And unless we know what's happening, we can't always take appropriate measures. So it's got to be a team effort to try to use the medications that we have to the best effect.